Thank you very much, Dr. Mackinson. Excellent presentation. It's tough to convince you that we need more imaging modalities after these beautiful images from Dr. Mackinson. And then you wonder why you need additional modalities to look at the mitral valve. So, as we all know, echo remains the first-line test, the most important test that every patient would start with. And it's an excellent test to determine the mechanism of MR, the severity, and then also for follow-up. However, there are some situations where it's tough to see by TTE the mechanism of MR. Sometimes you're uncertain about the severity of MR. Sometimes you see a lot of MR, but there is a discrepancy with the clinical scenario, meaning the patient is completely asymptomatic. And sometimes you need to plan an intervention and you need further anatomic assessment. In these cases, in addition to TTE, you can use exercise echo and TE, as Dr. Mackinson showed, but also you can rely on tomographic imaging with cardiac CT and cardiac MRI, which will be the focus of this talk. So let's start with cardiac MRI. What are the advantages? It is helpful if there is discrepancy, particularly between the clinical data and the echocardiographic data. It gives another way to quantify MR. As you all know, by echo, the main way to quantify MR is based on color Doppler. With MR, you get a different look at it, and you can do a volumetric assessment. It's an excellent tool for measuring the LV size and function because you see the endocardial borders in an excellent way. And then you can see if there is scar, meaning which has an excellent prognostic value. So this is a case of severe MR, post-mitral valve repair. By MRI, you can also get, short axis stack, meaning going down through the mitral valve. You can see where there is dephasing. Dephasing is a flow acceleration. And the way we look at it on MRI, it creates dephasing, which is a black appearance, and it correlates to the PISA on echo. You can then design long axis views across the mitral valve. So you can have like A1, P1, A2, P2, A3, P3. And then do a stack long axis going from one side to the other of the valve, so you can discern where the mitral valve leakage is starting, and then do dedicated long axis cine to see how the jet morphology, where it starts, and then how it's directed, as in this case. So MRI is excellent, as we said, for the LV size and function. You can see the endocardial borders, measure the LV and diastolic volume, LV and systolic volume, and get an accurate EF. And this has been shown to have an excellent predictive value, especially when the ventricle dilates beyond 100 cc per meter square, has been associated with worse prognosis. MRI can also, as we said, give you a different flavor, a different way to quantify MR. The way we do it is that we measure the LV stroke volume by end diastolic volume minus end systolic volume, and then we do Q-flow imaging, measuring the flow, the outflow through the aortic valve. And then once you have the stroke volume, you subtract the forward volume and you get the regurgitant volume, and then you can calculate the regurgitant fraction. And then a regurgitant volume of more than 55 cc or the regurgitant fraction more than 40% cc have been shown to be associated with worse outcomes. So again, another way to assess mitral regurgitation. Scar assessment is particularly specific to cardiac MRI, where you can see if there is gadolinium uptake, and which appears as a bright spot on delayed enhancement imaging, and this has been associated with worse prognosis. In patients with primary MR, we typically see it along the lateral and sometimes infiltrating the papillary muscles. And then the presence of scar portends poor prognosis, especially in the setting of severe MR. What about cardiac CT? Cardiac CT is excellent for anatomic details. You've seen excellent TE images showing all the details of the subvalvular apparatus. Sometimes it's tough to get them by echo, so cardiac CT can be helpful. It's a primary tool used to plan surgery, particularly redo surgery, robotic mitral valve repair, and surgery for mitral annular calcifications, and has a crucial role for transcatheter mitral valve replacement. So this is a case with prior repairs, a failed prior repair with severe MR. You can see the ring, and then you see that there is leak, and then the patient is high risk for redo surgery, so we're considering edge-to-edge repair in the ring. And the questions that you have is that you see the leak is central, but the main question is, do we have enough posterior leaflet for us to pursue edge-to-edge repair? And based on these images, it's very tough to see if there is enough leaflet to repair. So you're uncertain which one is leaflet, which one is chordae, where is the ring. So you can get a 4D CT, as you can see here. You can clearly depict the ring, and then go back to where the leak is, which is A2, P2, and then try to understand what is chordae, what is leaflet, and what is ring. And you can see here that you can measure the leaflet length and determine that you have enough leaflet length for tear and ring. And as you all know, not everything that's bright on echo translates into calcium. This is a case with severe, echo density on the mitral valve. And then when you do the CT, it turns out to be mostly caseous MAC rather than very calcific MAC. And this has surgical implications. Just it's much harder to go through a thick, rigid MAC, as I will discuss later. CT is ideal for the calcium location and distribution. You can look at the annular calcification, try to see how circumferential it is, if it's near circumferential or it's not. You can see if it's extending to the leaflets or if it's incorporating both the leaflets and the annulus. We have an excellent robotic mitral valve program, and one of the things that Dr. Gilinov always talks about is the screening of these patients, and all of these patients get a CT scan, and the main reason for the CT scan is to assess their candidacy for robotic surgery. We look at the aortic atherosclerosis, the femoral artery dimensions, and then the presence of any pectus, trying to select patients who would be a good candidate for robotic surgery. CT is also very important and to look for the cannulation site, particularly look at this case with porcelain aorta with prior radiation. This is a CT without contrast, and you see that the entire aorta is porcelain, so very hard to find a spot to cannulate. CT is also, we always routinely do it in cases of redo surgery, and the reason why, particularly for bypass, to see if there are any bypasses that cross close to the sternum, as in this case where you can see that the lima is immediately crossing behind the sternum, so there is a risk of injury upon re-entry. What about for MAC surgery? What we do is we look at the distribution of MAC, but also we measure the MAC, and there have been internal reports where, based on the Hounsfield unit of the MAC, the surgeon can determine if it's easy to cross with the needle, if they need to do debridement, and how extensive the debridement is. They also always ask us to look at the relationship of the circ to the lateral annulus, and to see how close the circ, so you can see, we can measure in 3D space the distance between the circ and the MAC, and determine if a preemptive bypass is needed, because especially in case you're planning to do extensive debridement. Finally, CT has a primary role in transcatheter mitral valve replacement. It is a central role. It can help in planning the access, whether it's transeptal or whether it's apical access. For anatomic, details, as we discussed, between distinguishing the ring from the leaflet, from the chordae, but also in novel devices like, the Carolan device, which goes into the coronary sinus. You can see the relationship of the coronary sinus to the posterior annulus, and then the interaction with the circumflex artery. You can simulate the valve and then size it, so you can embed the geometry of the valve that you have, whatever the valve that you intend to use, and then see how it's sitting. You can anticipate the fluoroscopic angles that will get you coaxial to the valve, so your working views ahead of the procedure. And of course, you can anticipate complications, primarily the presence of paravalvular leak and then LVOT obstruction. You can see here that, whenever there is gap, you wonder that if there will be a PVL in that area, and then you can measure the neo-LVOT and try to estimate the risk of LVOT obstruction. So how do we do it for transcatheter mitral valve replacement of native valves? So we first study the landing zone by measuring the annular dimensions, simulating the valve that we're going to use, and then anticipating the risk of LVOT obstruction, mainly because when you're implanting the valve, you're going to push the anterior leaflet towards the LVOT, and this anterior leaflet is at risk of obstructing the LVOT and causing LVOT obstruction. So we try to predict the risk by simulating the valve and seeing how it's going to sit and where the leaflet will end up and what would be the residual LVOT. We do the same for valve-in-valve. CT can help you see the calcifications and confirm that the valve is degenerated. You can simulate the valve, look at the LVOT, and then also measure the LVOT, the neo-LVOT, which is the remaining LVOT after the anterior leaflet has been pushed. And then if it's too small, then you can do leaflet modification techniques. So it has direct clinical implications. Similarly, for valve-in-ring, you can look at the ring, measure the leaflet, simulate the valve, and then measure the risk of LVOT. And then finally, for valve in MAC, which is a huge unmet need, you can see the MAC distribution, simulate the valve, try to see if there is areas that are uncovered, and try to predict if there will be a PVL, and then simulate the valve and try to measure the LVOT ahead of the procedure. So in summary, TTE remains the first-line diagnostic test of choice. Advanced imaging with cardiac CT and cardiac MRI can add valuable data. MRI is particularly helpful if there is discrepancy by providing additional quantification, different way to quantify the MR, and also it's very strong in terms of prognostication. And finally, cardiac CT plays an important role in surgical and procedural planning. Thank you very much.